Bismillah ar-Rahman ar-Rahim. Assalamu alaikum jami'an. I've been given the task to talk to you about the influence of female gender, or basically to answer the question, is female gender a fasting challenge? These are my disclosures. So the outline of my talk, I'm gonna first go through the challenges that face women with diabetes during fasting Ramadan. And then we'll cover some insights from the DAR global surveys of 2020 and 2022 on the non-fasting cohort, and cover some new data on the gender-specific characteristics of the cohort of the type 2 diabetes in the DAR surveys of 2020 and 2022, and end up suggesting some recommendations tailored to women's needs during fasting. Ramadan is a unique month of spirituality, of worship, and during this month, the women of the family carry the pivotal role of maintaining the cultural perspectives, preparing the food, and a lot of pressure are on women during this month to maintain this role. And fasting with diabetes is a challenge throughout life, throughout a woman's life, whether starting from the beginning of adolescence when they start fasting till they are elderly. So with adolescents, they start having their periods, the physiological challenges that they face due to the hormonal changes, and puberty. They do have increased growth demands and nutritional needs that may not be met with prolonged fasting. The fasting itself carries the risk of hypoglycemia, hyperglycemia, and dehydration. And then they face the psychological and social challenges of meeting the social expectations that they are now old enough and they should be fasting. They go through a lot of emotional stress, trying to cover up the days that they are not supposed to be fasting, with the period stigma. And the lack of awareness by communities and families in the need to support these young ladies in managing their disease, facing the challenges of fasting, is not always there. And all this is associated with many medical challenges in managing their diabetes, whether limitations in their ability to monitor. They are quite young and may not be able to adjust their medications properly in relation to meals. And this does put them at risk of diabetic ketoacidosis. As they grow older and they're now in the childbearing age, now they have more social and cultural responsibility. They still have the physiological challenges related to the hormonal fluctuations that does affect insulin resistance. They may be breastfeeding or pregnant. In addition, now they are the primary caregivers. They have many household responsibilities and social expectations. In many cultures, they still have the period stigma where they should not be showing that they are breaking their fast, and this does affect the way they manage their sugar or their ability to eat or monitor their sugar. And with all these social and cultural demands, it becomes very challenging to monitor their sugar and manage their diabetes, and puts them at risks for hypoglycemia with the prolonged fasting and all the work during the day, and hyperglycemia, and the weight issue, whether they're looking to lose weight during Ramadan or worried about the weight gain during Ramadan. And this issue of period stigma is really there in many cultures. It is pervasive, yet often overlooked, and it is a cultural challenge faced by women. Why does it matter when it comes to our patients with diabetes? Because it does put a lot of psychological stress that can impact the blood sugar. It puts them through a lot of emotional distress and pressure to hide their non-fasting, which affects their ability to take their medicine. It does disrupt the nutrition and leads to irregular eating habits and leads them to neglect their personal needs. And the fear of judgment can lead to some social isolation, their feeling of lack of empathy from their family or reduced support from their community can lead to them being excluded. And all of this does impact their blood sugar and their ability to control the diabetes. And then eventually, as older women, they go through the decline of renal function, hepatic function, the counter-regulatory hormone mechanisms are also impaired. They lose muscle, may suffer malnutrition, and therefore their glycemic risks are emphasized, in addition to the polypharmacy and other comorbidities that arise with age. And more women at this age are still very responsible for maintaining their household needs. And they do still face the social and cultural pressure from being expected to fast or shamed if not fasting. So typically, as you can see, and as you're all aware, when during the day, women are very busy, takes a lot of time away from their ability, which takes a lot of time from their ability to manage the sugar compared to the role of men, especially in the hours just before iftar. So what have we learned from the DAR Global Survey 2020 and 2022 in the cohort that chose not to fast? The main characteristics of this cohort, as you could see, so about 14.5% of the total cohort of 12,509 were the non-fasting, a total of 1,822. And out of those, the majority were female, 54.6% compared to 45.3%. And those women were older and had prolonged duration of diabetes. And many of them were on insulin therapy. There was a remarkable difference between countries, with countries like Saudi Arabia and Bangladesh, where the non-fasting rates was very low, at less than 3%, to countries like Turkey and Morocco, with more than half the population chose not to fast. But what about the gender-specific data? And these are the new data that we are presenting. So we looked into the characteristics of patients with type 2 diabetes, analyzing it based on gender for the surveys of the 2020 and 2022. The total female cohort was 6,559, slightly more than the male cohort. And the mean age in that cohort was not different in women versus men, around 55 years of age, with more patients in both groups with in the age group above 60. The average duration of diabetes was also similar between the male and female cohort, around 10 years. And the average A1C was more or less very close, 8.3 versus 8.4. However, for those who had an A1C above 9%, the proportion was a little bit more in women versus men, 29.4% versus 27.7%, though it was not statistically significant. When it came to the different medications used for the treatment of type 2 diabetes, there was no major differences between the male and female cohort. And looking into obesity and presence of other comorbidities, the female cohort did have a higher proportion of people with BMIs more than 30. So it was 32.6% versus 21.4% in the male cohort. Other comorbidities, hypertension was slightly higher in the female cohort, 51% versus 46.5%. The same with hyperlipidemia, 42 versus 41%. However, when it came to macrovascular disease, so coronary artery disease and stroke and heart failure and others, it was much less prevalent, significantly less prevalent in the female cohort compared to the male cohort. Also, markedly much less in the female cohort compared to the male cohort. Now, the fasting practices were not that much difference. So both around 86% in men, 84% in the female cohort were those who fasted the month of Ramadan with a mean duration of around 27 days, 0.2 in females, 28 in males. So not that much different. However, more women had the intention for fasting Shawwal compared to men, whether that is the Sunnah fasting or whether it was more to do the makeup fasting, it's not clear. When it came to hypoglycemia and hyperglycemia, women did have more incidence of hypoglycemia compared to men, 16.4% versus 14.6%. But there was no difference in hyperglycemia risk. And when it came to hypoglycemia, also the duration of hypoglycemia was more in women compared to men. So the incidence of hypoglycemia that lasted more than 8 days was 12.7% in women versus 9.8% in the male cohort. Hyperglycemia, however, was not much different between the male and female cohort, both in incidence or in the need to attend the emergency department or be hospitalized. It was also notable that a higher percentage of women reported not monitoring their blood sugar at all during Ramadan compared to men, so 26.7% versus 24.9%. However, the percentage of people that reported more frequent SMBG during Ramadan were not that much different between men and the women. Both the male and female cohort reported receiving similar education with brief sessions lasting less than 15 minutes, and it was not different between the male and female cohort. So overall, the key observations, I would say, that between the male and female cohort was that the female cohort had higher obesity rates, slightly poorer glycemic control, and more hypoglycemia, but they had less macrovascular complications. And the implications of this is that understanding women's caregiving roles and cultural pressures necessitates additional support during Ramadan. The non-fasting cohort data does highlight the importance of addressing clinical and regional factors influencing women's fasting decisions, and education and community awareness campaigns can empower women to take or to make more informed decisions. My recommendations was that women do need to receive individualized pre-Ramadan assessment, including the DAR risk scoring and proper education on self-management, targeted education on the importance of glucose monitoring, especially during Ramadan, in addition to nutritional counseling and community and religious engagement to empower women, increasing the awareness, reducing the pressure on them and the shaming, especially when it comes to the days that they are allowed not to fast. So in conclusion, I think women do face unique physiological, social, and cultural challenges during Ramadan fasting. Insights from the DAR Global Survey and the non-fasting cohorts emphasize the need for targeted strategies. These challenges need to be addressed through personalized care, SMBG education, and community engagement and nutritional guidance. And with that, I conclude. Thank you very much. وأسأل الله أن يبلغنا رمضان لا فاقدين ولا مفقودين وشكرا لكم جميعا.